This podcast is for educational purposes only and is not medical advice. For personal medical care, please consult a qualified healthcare professional. Welcome to Dermatology Undressed, a provocative podcast where the skin speaks and we have an opportunity to listen. I'm Dr. Lindsay Ackerman. Today's episode, Skin Cancer, Truth and Consequences. I am absolutely delighted, and I mean delighted, to welcome our guest today, Dr. Marta Van Beek. Dr. Van Beek's line of credits could literally take nearly our entire podcast, so I'm going to limit this to a condensed version solely for the interest of time. Dr. Marta Van Beek is a professor of dermatology at the University of Iowa Carver College of Medicine and holds the prestigious title of the C. William Hankey Professorship of Dermatologic Surgery and Cutaneous Oncology. Dr. Van Beek is a nationally recognized Mohs surgeon, health policy leader, and advocate who currently serves on the American Medical Association Board of Trustees. She has also served as the chief of staff for the University of Iowa Hospitals and Clinics, where she is both a Mohs surgeon and the director of the Mohs Micrographic Surgery and Cutaneous Oncology Fellowship. Dr. Van Beek has chaired multiple national dermatology and legislative councils, including the American Academy of Dermatology's Congressional Policy Committee and Council of Government Affairs and Health Policy. And she played a major role in the implementation of DataDerm, now the largest dermatology clinical registry in the world. And maybe, above all else, I feel uniquely positioned to say she is just an outstanding human being, a dear, dear friend, a wife, mother of three, and among the most spectacular humans I have ever come across. So, Dr. Van Beek, welcome to Dermatology Undressed. Thank you so much for being here.
Well, Dr. Ackerman, it's such a privilege to be here. I am a big fan of you as a person and actually what you're doing for public education for the specialty of dermatology. So thank you. It's an honor.
Well, thank you. I mean, I can't actually believe we managed to make this happen with our schedules and so forth. But, in the interest of time and on the purposes behind this public education campaign, I want to start with skin cancer. This is Skin Cancer, Truth and Consequences. Yeah. We talk about prevention. Do you think the public really understands what that means? What are we trying to achieve by prevention with our public education campaigns in skin cancer?
Well, I think we're really trying to decrease the numbers of skin cancers that get diagnosed every year. And I think, we've had a long-standing public education campaign, but probably not as intense or as powerful as other countries like Australia or New Zealand that have been really powerful public education campaigns. But I still feel like the average public member is pretty cavalier about the most common risk factor of skin cancer, which is sun exposure.
Why do you think it's taking us so long to get this message to penetrate? Is it a cultural thing? Is it something that patients just don't want to have to do? It's another life burden to throw a sun protective shirt on or some sunscreen or avoid the tanning bed? Why are we having so much trouble?
I think it's all of that. I think, when we do recreational activities, it's outside, and to put sunscreen and protective clothing on, maybe when that has not been a lifelong habit, is an extra burden and something you don't think about. I have I have the privilege to work in Iowa, and so I have a lot of outdoor workers and farmers that are my patients, and they actually kind of don't like the sensation of a sticky sunscreen or to have to reapply it when they're outside all the time. Is an extra thing to think about. But when we have a conversation with them where they're in having a skin cancer removed or I'm doing a large reconstruction, they say wearing the sunscreen and the protective clothing is well worth it. So I think a lot of people just don't understand the trade-off of what the consequence is of having a skin cancer.
I think that's really well put. So let's go back to just frequency here. Skin cancer happens to be the most common cancer in humans in the United States. How often are people getting skin cancer? What's our overall incidence rate these days?
So there are many types of skin cancer. The most common types of skin cancer are called non-melanoma skin cancer. Basal cell and squamous cell carcinomas are the most common type of non-melanoma skin cancer. And we estimate 5 to 6 million of those are diagnosed every year. That's 1 in 5 Americans that will develop a non-melanoma skin cancer before the age of 70. And then
Wow.
we also have melanoma. And melanoma rates are rising astronomically over the past decades. It's less common than non-melanoma skin cancer, but still increasing. And we think there's over 200,000 cases of melanoma that are diagnosed each year, or that will be diagnosed by the end of 2026.
Gosh, do you think that we run the risk of, because non-melanoma skin cancers are so common, you're saying 1 in 5 Americans prior to the age of 70 will be diagnosed with one of those two types of skin cancer. Do you think we run the risk of basically kind of patients thinking, well, it can't be that bad, right? I mean, is it even the good cancer? Do we tell patients, well, if you had to choose a type of cancer, I guess you chose the right one.
No. And as physicians and dermatologists, we often say that phrase because we're trying to actually or give the patient a perspective of what type of cancer they have. And so I have been guilty of saying, if you had to pick a cancer, this is the best kind to have, but it's not a good cancer.
I've been guilty of the same messaging. Yeah.
Yeah. It may be the least aggressive, but still if you have a basal cell carcinoma, while it may not metastasize or spread to other areas of your body, it will destroy the tissue where it is. It will cause an ulcer. It can eat through muscle. It can eat through bone.
And frankly, just to eradicate the tumor might leave you with, some degree of a facial disfigurement.
Yeah. And I think there's a lot of misconceptions about what skin cancer surgery is. Often patients will come and see me for the first time and say, oh, you're just going to do a little scrape and then I'm going to go home. And I have to explain to them, no, I'm going to excise it with a scalpel, and I'm going to actually reconstruct that defect or that hole that I left you to make sure that everything is symmetric. And then all of a sudden, I think reality sets in, and they realize that skin cancer, even though we can cure them with an effective surgery, is a physical and emotional burden to undergo surgery and the healing process.
It is 100% life-changing. I mean, every one of my patients who didn't quite comprehend what this burden of a common cancer or the cancer to choose, if you had to choose a type of cancer, that actually undergoes the surgical experience of having it extirpated, having it removed, their face reconstructed, their ear reconstructed, wherever it might have been, they show up the next time a lot more teed up on what they're going to do to not have to go through that again. That's for sure.
You are exactly right. I mean, it's a really hard way to learn the lesson, but I would say after they've had Mohs micrographic surgery or even a simple wide local excision, they are much more proactive about sun protection then.
Yeah. So on the angle of sun protection, how we can use this forum right now to help educate. Talk to our population that are listening right now about UV radiation. Where is it coming from? We hear UVA and UVB, and what is the sun protection factor? And how do patients actually translate what we're telling them, that they need to start thinking seriously about protecting themselves from this quote unquote common cancer? How can they use this information to implement something that's going to help them?
Yeah, I think you can get lost in the details of UVA, UVB, SPF. So I'm just going to break it down. So UV rays come from the sun. UVA rays are longer. They penetrate deeper in the skin. UVB rays are shorter. They also penetrate the skin. And UVC hopefully doesn't really penetrate much of the Earth's surface because it's profoundly carcinogenic. But both UVA...
And that carcinogenic just means cancer causing.
Oh, yeah, sorry. Profoundly is very damaging to cells. And both UVA and UVB, historically, one has been called a tanning ray, one is called a burning ray. It really doesn't make any difference. They both damage the skin in different ways, but they both contribute to your risk of skin cancer and premature aging and wrinkling.
Yeah. And so when we're getting UV radiation, does it have to come direct from the sun? Are we also getting radiation, that might be bouncing off of surfaces and being amplified? It's easier to get a burn when you're, on the water, right? Because you're getting it two ways.
Yeah, right. No, you're exactly right. There's reflective surfaces that increase our exposure all the time. And then the whole myth about that you can't get a sunburn when it's a cloudy day. I mean, most of the people that I see with unexpected sunburns they were caught outside on a cloudy day longer than expected.
Yeah.
So I think we need to making a habit of protecting yourself from the sun, whether it's sunscreen, protective clothing, or seeking shade, regardless of the weather, is only going to be do yourself a favor in the long run for your skin health.
Yeah. And I'm not a physicist by any means, but I think that some of the rationale, like the worst sunburn you ever get is a cloudy day on the beach in San Diego, it's that the rays get trapped. Actually, they can penetrate through, but somehow when they're reflecting back and should be bouncing back into the atmosphere, they're otherwise getting trapped closer to the earth, and we're actually getting a more intense exposure. And intensity of exposure also for, patients that might be visiting higher elevations or living at higher elevations, that too plays a role, right? Where the air is thinner and more is penetrating down.
Elevation and latitude all makes a difference, and of course season. I mean, you can get sunburn in the winter, but you also have to use a stronger sunscreen and apply more frequently in the summer, depending on the latitude of where you live. Absolutely.
Yeah. And then the idea of a burn versus cumulative exposure. Can you expand a little bit on that? Is it only if you get a sunburn are you really at risk?
Yeah. No, all sun exposure damages cells. So when we think about a sunburn, of course, that's acute injury. We know that we've damaged the skin. A sunburn is your skin screaming, saying, how dare you not protect me? I'm injured. I need to do all this to repair myself. A tan is your body's response to try to prevent you from injuring the skin after it's already been injured. It's a reparative response. It's had enough sun exposure that's saying, I need to protect myself from more sun exposure. So there is no such thing as a healthy tan. You have to damage the skin in order to set off the cascade to start the tanning process. Yeah. You don't want to damage the skin to start that process.
Right. So that whole idea of, let me get a tan before I go to the beach, Wow. Look at what we've done to ourselves culturally here.
I mean, the analogy is cigarettes are safer if I smoke a couple before I start smoking another pack. I mean, that's just ridiculous, right?
Totally ludicrous. And, the tanning bed industry probably won't like that we're talking about this, but, that's one of their biggest claims to fame is come with us. Let's get you tan so that then you can go on your summer beach vacation and have less damage. What?
Right. I know. Yeah. We used to call them cancer coffins, right?
Yeah.
You ever call them?
Yeah. No, right. No, indeed. I think at one point the tanning industry actually had a larger lobby in the U.S. than the tobacco industry. They may still.
Prior to 2010, 2015, I think you were probably right because they had the whole vitamin D inappropriate disinformation campaign. Exactly. That's a whole other podcast, right?
Right.
But I think what's concerning is just recently the FDA has retracted the ban on tanning beds by minors. That was something put in place in 2015 because the evidence was overwhelming that tanning bed use dramatically increased your risk of all types of skin cancers. And just now they have retracted that ban, which I think sends the wrong message to the public.
100%.
Thankfully, there are some states that still ban tanning under the age of 18, which is what the original ban for the FDA was, banning tanning for minors to try to keep young people safe from the risks of a known type of carcinogen.
Yeah, I think actually indoor tanning may cause more cases of skin cancer than smoking causes of lung cancer in the United States every year.
Yes.
I mean, that's a remarkable statistic. And that's not, just skin cancer incidence rates being higher. That is indoor tanning being directly linked to the incidence of skin cancer. And indoor tanning is highly, highly associated with the risk of melanoma. We're talking about the commonality of non-melanoma skin cancer, but melanoma specifically being a quite aggressive type of skin cancer, one that has been, I think, the leading cause of death for women that are young from cancer. So if you're like 19 to 29 and you're a female and you're going to die from cancer, melanoma is still the number one cause.
Yeah. And the link is so strong that it's in almost all the questionnaires when you see an oncologist and are diagnosed with melanoma and or a dermatologist. So we know the link is there.
So we're talking a lot about tanning beds and tanning. I want to just focus on one thing because we know the biology, trained as physicians and dermatologists, we know the biology as to why it is something that actually feels good. People tend to have a sense of maybe not quite euphoria, but they feel good when they tan. Can you explain to the audience why that is?
Yeah, I mean, I think your analogy of euphoria is quite on. Sorry about that. Yes, I think your analogy of euphoria is correct because when you tan, we have demonstrated, or science has demonstrated, that actually affects your opioid receptors. So it does make you feel content. it does satiate those opioid receptors. And so that is why we know it's addictive. And I'm sure you have patients just like I do that have tanned, and it's very difficult to break that cycle because they feel better and they have those opioid receptors satiated, and it's hard to break that cycle.
It's almost like a withdrawal.
Yeah, and trying to work through that with a patient can be a lot of hard work because they know that it's bad for their skin, but they're addicted. And that's been shown in multiple cross-sectional studies.
Yeah, and it's actually the hormone, that pro-opiomelanocortin, that I'll sometimes have this conversation with patients and say, I get it. I know it feels good. It's almost like taking, Percocet. You're getting an opiate sensation because when you tan, your skin is actually sending this incredible signal to your brain that, oh my gosh, UV light is really intense on my skin. That signal goes to the brain. This brain says, I'm going to try to make my cells make pigment to protect. Right? So in making that signaling, there's a long protein called pro-opiomelanocortin, opio, getting spliced off and satiating the opiate receptors. Yeah. So,
and I think it's important that we recognize that it is addictive and recognize that it's really hard to ask some of our patients to stop that cycle. It's hard as a patient to hear somebody say, quit smoking, quit tanning, it's bad for you, versus somebody coming alongside you and saying, I know you've been doing this for years. I know it makes you feel better. I know I'm asking you to do a really, really hard thing, but it's going to be for the benefit of your skin, and I'll walk alongside you. We'll help you taper off. Using topical self-tanners are safe and sometimes can help people. They don't give you that opioid receptor feeling, but they actually give you the look that you want. They've come a long ways in the last couple of decades and can help people kind of defervesce. So
yeah, no, that's perfectly. I mean, I'm so glad you're bringing it up because it's actually part of our counseling rather than just directing with this sort of command of, okay, you must stop doing this. How do we help them along? Because we really do know they struggle and it is addictive. And maybe they have to have some other feel-good activities like, dancing in the shower naked carefully, but, to great music or doing whatever else makes them feel good.
Does that help your opioid receptors? Maybe it does.
Yeah, maybe. I don't know. I might try it sometime though. We'll see. Yeah. So you are a Mohs micrographic surgeon. You are actually an incredibly well-renowned Mohs micrographic surgeon. You run the fellowship at the University of Iowa. Tell our audience, what is Mohs micrographic surgery? How do you spell it? Where did it come from? I mean, people are constantly butchering the word, so let's give them some intel on that.
Yeah, I'd be happy to tell you how to spell it. It's Mohs. It's not an acronym. It's actually named after a physician that really was the pioneer of a new technique of a stepwise method of removing a skin cancer. So Mohs micrographic surgery is where we outline what we think the skin cancer is. We take an extremely narrow margin, and then we use frozen sections, look at the specimen underneath the microscope, and we use a special way to cut the tissue. So we're looking at 100% of the margin. So we can search the deep margin, the peripheral margin, and we draw a map of that specimen, look underneath the microscope, look to see where there is skin cancer, and we'll mark on the map where there's residual skin cancer. And then we'll go back to the patient with the map out exactly where it is, and take a small piece of skin that corresponds to where there's still skin cancer. So
you're kind of charging your way around the tumor cells, right? That first map you make, it might be positive on the patient still at what's equivalent to 2 o'clock.
Right, exactly. So then we just take 2 o'clock and leave the rest because we know that's clear. And then we look at that underneath the microscope. And so we're essentially chasing the skin cancer out that we can't see with our naked eye. And then we are able to take the narrowest, almost even a microscopic margin, and know that the skin cancer is clear. So it has an extremely high cure rate because we're looking at 100% of the margin, compared to a wide local excision where they may only look at 15% of the margin, just by the way that they process it and look at it underneath the microscope. But the benefit of this is we keep the hole or the defect as small as possible, but still cure it.
And you just mentioned something that's really important too. And I do wide local excision. I'm not trained as a Mohs micrographic surgeon. And so in regions of the body where we can have wider margins and, the consequence of that from a surgical risk standpoint and cosmetic standpoint is negligible. It's not any necessarily worse to do, maybe in the middle of someone's back. But you called out something that's interesting that I don't think most people know, and that is in those tissue specimens that we ultimately send out to the lab, they assess about 15 to 20% of the margin of what we've cut. So we know, though, I mean, I think the public should also know that from evidence-based guidelines, if we take that larger margin, the 4 millimeter margin, say on a non-melanoma skin cancer that's maybe less than a centimeter or slightly over a centimeter in size, we have still a very high cure rate, 96%
Absolutely.
or so.
Yes.
But the margin they're looking at, I use this analogy, I call it bread loafing. And I'll tell the patient, they'll say, well, are they going to look at to make sure it's clear? And I'll say, they will. But to be totally honest with you, they're going to look at the crust on a slice of bread, like crust on slice number 2, crust on slice number 6, on slice number 9. And if those are clear, they'll call it clear. Where, there's a remote possibility that there could have been a little, leg of the cancer that was moving out to another margin that we just didn't capture. And that's why we're 96%, not 100%. But Mohs, because it assesses 100% of the surgical margin, really it would almost be human error if it recurs, presumably. Yeah. So it's 99+% cure rate.
Yeah, I don't think anything is 100%, but 99, plus percent. And as a Mohs micrographic surgeon, I do a lot of wide local excisions off the head and the neck, where we can take a wider margin. It's easier, less time consuming for the patient, and we get, a net cure rate of 96%, which is fantastic. So there are appropriate places to use Mohs, and there are inappropriate places to use Mohs. So you don't want to you wouldn't use Mohs micrographic surgery on every skin cancer anywhere in your body. It's for specialized
But in places where, I like to say there's limited real estate, the tip of a nose, near an eyelid, someone's ear, their cheek, those places it becomes remarkably important that Mohs is utilized to remove the cancer, high cure rate, and less cosmetic defect.
Right.
And maybe even less functional defect. I'm sorry, I'll let you.
No, you're exactly. Less for the cosmetic and functional, because 2 to 3 millimeter difference of the size of a defect or a hole that we would leave after removing the skin cancer on the nose could determine whether we can close something linearly in a straight line or have to do a flap or a graft. And there's major differences in reconstruction for aftercare, healing, and cosmesis, depending on how we fix it. And so those 2 to 3 millimeters make a huge difference in the way we our reconstructive options for the patients at the end.
And even risks of infection and postoperative bleeding, and say it's near your eye. I mean, if you pull just a little bit more down on your lower eyelid, your eye may not close at night, and then you have a dry cornea. I mean, there are multiple reasons why Mohs really does limit the adverse outcomes that can happen from surgical excisions of the head and neck. So, what drove you to take care of skin cancer? Why is this your life's work?
I think, we're all attracted to dermatology because we get to treat the breadth and depth of all patients, right? I am particularly attracted to Mohs micrographic surgery, not only because of the procedural aspect, but I have the pleasure of having a prolonged patient encounter. So I get to spend time with my patients while I'm doing surgery on them, while they're awake. I get to learn about their family. I get to learn about their challenges. It is the greatest privilege ever to have that protected time with a patient. I mean, granted, I'm sure they would like to be somewhere else, but I absolutely...
But they can't go anywhere when they're on the operating table with you.
But it is an absolute privilege that I cherish, because you get to find out some fascinating things about patients. Yeah.
I know. I adore you. This is one of the many reasons, but you're just such, I know you philosophically and genuinely, authentically feel that way, and I love that. So let's talk about your work in advocacy. I mean, we know that day to day you show up every day to have that relationship with the patient where you could be saving their life, you could be saving their face, teaching them and helping them to risk adjust over time. But you have an entirely different dynamic to your professional work, and that is you have a master's of public health for sure, not to go unnoticed, but you've also dedicated the entirety of your professional career to, alongside providing patient care, education to residents and fellows, to working on the side of making sure patients that deserve access to care can get it. Talk to me about your work in advocacy. What do you find most meaningful? Where would you like to see things change? Give us a little bit about that part of Marta Van Beek.
That's a really important question. Why I do advocacy in the first place is the same reason you do, Dr. Ackerman, is because we treasure that patient-physician relationship. We spend time and training to be able to meet with the patient, develop the right treatment plan for them, for their particular social situation, for their particular severity of disease. And we want to be able to preserve the fact that we write a treatment plan, that will be implemented and covered by their insurance, and that the patient would have access to that. So why any physician gets involved with advocacy is because they're frustrated because something in the system is interfering with their ability to actually write the right prescription, for the patient to have that covered, for the patient to be able to have access to the physician because of their insurance coverage or because of workforce shortages. So, we're all doing this because we love the patient-physician relationship, and we're frustrated that somebody or some construct or some entity is interfering with our decision-making process and with our ability to take care of our patients. So, it's really, that you want to change the system and you want to preserve what you know is right for the patient.
Yeah, you're right on. I think a lot of people listening probably don't even know that physicians do that work, that we show up and we help write policy and we help to make sure that behind the scenes there is so much. Everybody knows about, oh my gosh, I can't get my prescription filled, or it takes so long to get into a doctor's visit, or I'm feeling like my doctor's visits are getting shorter and shorter and it's tough. And that there's a battle there that a lot of physicians step up to the plate and dedicate a tremendous amount of time to trying to resolve. It's thankless work at times. You feel like nobody knows the efforts and the hours that go into it, but the frustration is present on both sides of the equation. We recognize it, and you and I have been doing this for over 20 years together in public policy and advocacy.
It's a blast to partner with you, Dr. Ackerman, because to go to these various meetings like the AMA and write policy and testify pro or against policy is important things for what we do, and it is so important. And the other thing is, the thing about medicine is everybody has an opinion about how it should be delivered, but until you are either in the health profession or until you've been sick and know the challenges of being sick and trying to navigate the healthcare system, until you know what that feels like, I don't think it's very easy for you to make decisions of how it should be delivered. So
I couldn't agree with you more, for sure. So I'm going to take us full circle. This is Skin Cancer, Truth and Consequences. So from the perspective of being physicians that manage skin cancer, that want our patients to actually give us less work to do, if we understand the risk and the consequences, what is our obligation as a profession to act?
Our obligation is to continue the policy work that we're doing, making sure that policymakers know that tanning beds are dangerous, that outdoor workers should be afforded some sort of education and protective materials from sun exposure when they're outdoors, that we have public education campaigns, and that we have access to dermatologists that can intervene early, diagnose and treat the skin cancer. And, there's all sorts of preventive services we haven't talked about for topical chemotherapy that we can actually come alongside these patients with. So we have to continue to advocate for access, for coverage, and for public education campaigns.
Yeah, and because you went there, I'm just going to mention something that we haven't talked about, but I think is really important for the public to understand, and maybe even those that are making the rules we all have to play by, legislators and payers, and that is, if someone were to walk into your office, if they had access to you or a dermatologist, otherwise equally skilled, to do a good full-body skin cancer evaluation, and that patient is diagnosed with melanoma, and the melanoma is early, so we can excise it. We're talking about a wide local excisions done in the office, in the outpatient setting. The total cost to the healthcare system of that experience is probably under $1,000, right? Between the visit, the biopsy, and the excision and closure, around $1,000. And these are over subsequent visits, right? If you alternatively do not have access to the doctor, the melanoma that was there does not get diagnosed early. Instead, the melanoma is found 9 months later when someone has a cough and it has metastasized to their lung. Now that patient might need radiation, hospitalization, immunotherapy, right? And they may need immunotherapy for a lifetime. we are probably talking on the order of millions of dollars of care delivered to that patient over time.
Yeah. Lost millions of dollars worth of care, lost days of work, having to come in for infusions and radiation treatments, which is not only disruptive to the patient, but disruptive to their entire family circle.
Yeah, well, and potentially the loss of their life. I mean, let's not forget to mention that. But yeah, I think from a cost-benefit perspective, there have been a number of publications, we're not going to get into those here, but that actually demonstrate that dermatology is one of the most efficient executors of care as a medical subspecialty. With our ability to do so many diverse things, to look under a microscope, to do surgery, to actually do the screenings, to come up with medical therapeutics, as you mentioned, topical therapies sometimes can cure cancers without even having to take a surgical scalpel to someone. So, okay, we're going to get close to the end here, but I have to ask you this question. What future directions excite you most about what's coming next in our next chapter in skin cancer, whether that's diagnostics, prognostics, therapeutics? What's most exciting you?
I think probably therapeutics, because I treat a lot of, I'm a referral center, quaternary or tertiary referral center. So I see a lot of patients that either have had recurrences from outside, that have been treated on the outside, and or that have very, very severe disease. So a lot of people that have had organ transplants often have an immune system that's a little bit challenged, and often they have very aggressive tumors. And so while we have come a long ways with therapeutics for melanoma, we still have a long ways to go for squamous cell carcinoma. There are some really exciting new therapeutics out for metastatic squamous cell carcinoma or squamous cell carcinoma that's spread beyond the skin, but we still have a long ways to go. And those are a patient population that I see a lot that suffer if they don't get diagnosed early and aren't managed methodically by a dermatologist.
Yeah, and given the commonality of those skin cancers, and actually, like you say, the patients that are otherwise now getting transplants of their liver because we can do that more readily, they're on these other medications that put them at higher risk for aggressive tumors. We're seeing more of those patients living longer and now, developing those cancers, and we've got to find an adept way to handle them to let them live out the rest of their life successfully.
Right. I mean, people often forget that all of the progress we make in one arena often has a consequence for a side effect in another. So organ transplantation, bone marrow transplantation is amazing, but it comes with a lot of side effects because we suppress the immune system and they have a higher risk of skin cancer.
Yeah, and how dare us ignore that that's part of the equation that we're delivering them. Coming close to the end, rapid fire, truth or misconception? A base tan protects you.
100% false. You have to damage the skin to get a tan. So it does not protect you. You damage it in order to afford a tan.
You don't need sunscreen on cloudy days?
Myth. You absolutely need sunscreen on cloudy days. You can still get a sunburn, especially when you're near reflective surfaces.
Darker skin doesn't get skin cancer?
Darker skin does get skin cancer. And when we think about often patients with darker skin may not think they're at risk for skin cancer. Sometimes they get diagnosed later because of that.
Yeah, also sometimes more difficult to diagnose, more difficult to see.
Absolutely.
One severe burn matters more than cumulative exposure?
They both matter, right? A severe sunburn increases your risk of melanoma. Cumulative sun exposure increases your risk of non-melanoma skin cancer. They both add risk. You want neither.
Well said. So if there's one thing this conversation makes clear, skin cancer is not trivial. It is not cosmetic, and it is not optional to take seriously. The truth is visible. Our skin is asking us to protect it, but changing in front of our eyes. The consequences are often not until it's too late, however. Dr. Marta Van Beek, my dear, dear friend and brilliant colleague, thank you so much for being with me today. It's been a pleasure.
Dr. Ackerman, it's been an absolute pleasure. Thank you for all that you do for your patients in the specialty.
Thank you.
And next time, I'll iron my shirt.
We're all good. Like I say, your content is more compelling than the condition of your scrubs. It's been a day, right?
Yeah.
It's been a day.
I mean, the hospital, these are hospital issues. So I'm in the hospital.
Scrubs, these are not you. You know, anyway, you got to go back to the hospital, tell them to iron better. Of all the things you're working on in advocacy, I mean, that should be top of list.
I'm not going to her to help her rearrange my face. She can't even iron her shirt. I'm just like, this is wrinkly.
For the listeners, that ironing of the shirt is done by the hospital. If there there's one thing this conversation makes clear, it's this. Skin cancer is not trivial, it is not cosmetic, and it is not optional to take seriously. The truth is visible. Our skin is asking us to protect it by changing in front of our eyes. But the consequences are often not visible until it's too late. Don't forget to subscribe, rate, and share this episode of Dermatology Undressed, a provocative podcast. Until next time, stay curious, stay kind, and keep peeling back the layers. When the skin speaks, it's never just skin deep. This is Dermatology Undressed.